welcome everyone to this month's Fireside Chat in honor of Lung Cancer Awareness Month. Let me actually get my slides. Just give me one moment here to get those up. All right, so the Fireside Chats are brought to you by the Office of Community Engagement at the Masonic Cancer Center at the University of Minnesota. The Office of Community Engagement serves as a bridge between the Cancer Center and communities across the state of Minnesota. So our team's mission is to reduce the burden of cancer in Minnesota by engaging communities and providing them access to knowledge and information on the latest cancer research, cancer prevention, the importance of screening and early detection, treatment options, survivorship, as well as clinical research opportunities. My name is Amna Hussein. I am the Community Engagement Coordinator on our team. And on behalf of our team, thank you all so much for joining us today in observance of National Lung Cancer Awareness Month. Lung cancer is one of the most common cancers diagnosed in both men and women in the United States. Although smoking is the leading risk factor for lung cancer, you don't have to smoke to get lung cancer. According to the American Cancer Society, as many as 20% of people diagnosed with lung cancer in the United States have never smoked. So this means that more than 40,000 cases of lung cancer diagnosed each year are in people who don't smoke, more often in women than men. These can be caused by exposure to radon, secondhand smoking, air pollution, and exposure to certain cancer-causing chemicals. So today we are joined by pulmonologist and researcher, Dr. Abbie Begnaud, and lung cancer survivors, Steve Kuczenski and Chris Shillock, for an important discussion on lung cancer, understanding the common risk factors, and lung cancer screening. First, we will be hearing from Dr. Abbie Begnaud. Dr. Begnaud hails from Louisiana and arrived at the University of Minnesota in 2013. She is a lung health expert who diagnoses and manages common lung diseases, including lung cancer. Her research focuses on reducing the impact of lung cancer through early detection, which is screening, especially for groups who are disproportionately impacted by the disease. Dr. Begnaud has been fortunate to partner with Indigenous organizations to reduce the burden of lung cancer in this community. In addition, she is active with the American College of Chest Physicians and A Breath of Hope Lung Foundation. I will introduce Steve and Chris later on in our program. We will be recording the session today, so you can refer back to the recording on our YouTube page. Before we begin, I would like our audience to get familiar with using the Q&A feature, which is located on the bottom right of your screen. During today's presentations, please use the Q&A feature to submit your comments, reactions, and questions so that we can address some of those questions during the Q&A portion of our program today. All right, without further ado, I will go ahead and pass it over to Dr. Begnaud.
Thank you, Amna. I'm excited to be here with you today, even though I am a little under the weather, both physically and sort of metaphorically. But this is a really important topic, so I would not miss it for the world. So I took a bunch of Dayquil, and here we go. So I'll start with a little bit of background about different types of cancer. I know we have a mixed audience, but I want to make sure we all have a bit of an understanding of where we are. So, there are many different types of cancer, and usually we name cancer in one of two ways. We might name it based on the body organ where it starts. So some examples of that would be breast cancer, lung cancer, colon cancer. For example, we're talking about lung cancer today. But another way that you can think of classification or groups of cancer or the type of cell that turned into a cancer cell. So a blood cell, a bone cell, a lining cell. So these different types of cancers would be called sarcoma, leukemia, lymphoma, carcinoma, which is usually what's in the lung, and that usually relates to a lining cell, like a cell that's lining, like the windpipe, the bronchial tubes. Why does cancer happen? So it's all about the genes. Genes can be inherited, of course, and then genes can also mutate over time. So a lot of different things can cause genetic changes in the body. Radiation, like from the sun, exposure to chemicals, exposure to viruses, and exposure to harmful substances such as cigarette smoke, and just cells dividing. As we grow, as our bodies grow and maintain themselves over time, the cells are constantly dividing. And every time there's a division, there's an opportunity for a mutation. So we can think of genes as the recipes in our body. This little cartoon shows a cell in the body, and in the nucleus, there's a chromosome, which is made up of many different strands of DNA. So think of these like recipes, okay? So I've made a recipe like this before. I'm not an excellent cook. And so sometimes I do make mistakes, and that's how it is with genes as well. They're much better. They're much better at making things than I am, but they do still make mistakes sometimes. So, an inherited genetic problem could be considered a bad recipe. The recipe that you have is just inherently bad. They put the wrong amount. 1 cup instead of 1 teaspoon of salt is going to make a big difference. Other genetic mutations can happen due to the environment or exposure. So you might think of this as your ingredients have spoiled. If you left a milk product out and then you use it in a recipe, that might mess up the whole thing. Or you might think of bad luck or some unknown factor which impacts the outcome of your recipe or of your genetic divisions. So this might be your oven temperature was off, or, they always have those disclaimers for if you're making this at high altitude, things are going to be a little bit wonky. So you have to do things a little differently. So I think this is a kind of a real world example of what happens with cancer. Why does cancer happen? It's mutations in the normal process that usually works pretty well. So how big of a problem is cancer in general? It is a big problem. I'm sure everyone on this call knows someone whose lives have been touched by cancer if they haven't personally. So nearly 2 million new cancer diagnoses in 2020, 600,000 people died of cancer. Almost 20 million cancer survivors, but about 4 out of people will be diagnosed with some kind of cancer in their lives. In Minnesota, we have slightly higher incidence or occurrence of cancer compared to other states in the United States, and actually slightly lower mortality, slightly lower death. So it is true sometimes what they say that all Minnesotans are above average, I guess. This is a little bit of a graphic representation of the leading causes of cancer death. On the right side is a table which lists the most common types of cancer, and they're listed in order of occurrence or incidence. So you can see breast cancer in women is the most common type of cancer that develops. The next column shows you how many new cancer cases, new people were diagnosed with cancer in 2019, and it shows 268,600 women diagnosed with breast cancer. Next to that, it shows the estimated deaths, how many people died of that cancer in that year. So you can see the most commonly occurring cancer is breast cancer, but a fraction of those people actually died. The second most commonly occurring cancer is lung cancer at 228,150. This is an estimate from a couple of years ago. But if you look at the estimated deaths for lung cancer, that number is much higher. It's a much larger proportion of this number here. So actually, if you look over on the right-hand side, you'll see that 142,000 estimated deaths from lung cancer a couple of years ago is by far the highest number of any of the leading cancers. So on the left side, I've got a little pictorial representation. If you took all of the people who died of colon cancer, breast cancer, prostate cancer, and poured them into one container, that would be how many people died of lung cancer. So lung cancer is the leading cause of cancer-related death in the United States, in Minnesota, and in the world. So that's why we're talking about it today, because it is a huge, huge problem. So who can get lung cancer? The short answer is anybody with lungs. Risk factors, as Amna mentioned, are exposure to smoke. So cigarette smoke, whether you're inhaling that smoke yourself, secondhand smoke, even exposure to other kinds of smoke from other burning substances. Exposure to asbestos particles has been attributed to lung cancer. Exposure to radon, which I'll talk a little bit more about radon, but radon is a naturally occurring gas that is odorless and colorless and is present in many homes in Minnesota. And radon is thought to be the second leading cause of lung cancer behind cigarette smoke exposure. Yeah, exactly. Air pollution also is more recently been recognized. I'll share with you some recent study data that air pollution is most likely related to lung cancer as well. Family history is an important part of who can develop lung cancer. We talked about, inherited genetic mutations as well as genetic mutations that can develop over time. So anybody with what we call a first-degree family history, so siblings and parents who had lung cancer are also at an increased risk of developing lung cancer. Here's some of that new science on pollution and lung cancer. So this little cartoon shows you a graphic representation of these particles called PM 2.5. So particulate matter that is smaller than 2.5 microns in diameter. And this shows you how many of those would be present in the human hair. So it's something that is the size of a fraction of the human hair. These particulate matter are included in pollution, basically smog and other things when there's poor air quality. And this causes inflammation in the lungs. You don't see it, you don't really smell it. You breathe it in and it goes into your mouth, into your windpipe, all the way to the very farthest corners of your lungs and can cause inflammation. And some new this new research was published, was presented just this year at a conference in Europe, showing that this inflammation is waking up cells in the body that cause these cancer-causing mutations. They showed a link to a specific type of lung cancer called EGFR, epidermal growth factor receptor lung cancer. And this is a common type of lung cancer that's found in people who have never smoked cigarettes. So we're increasingly recognizing that exposure to pollution is also an important component of who gets lung cancer. So I'll focus a little bit on treatment, and then I'm going to backtrack a little bit. So lung cancer can be treated in a variety of different ways: surgery, radiation therapy, different drug therapies, in addition to supportive care aimed at managing any symptoms that go along with developing the cancer. And how we choose among these options is based on a lot of different things. So cancer treatment specialists factor in the cancer type, like we talked about, the lung cancer, the stage of the cancer. I'll tell you a little bit more about staging, and then biomarkers as well. So biomarkers are some really specific features about different types of cancer that we now have some better treatments for. So staging is really important. This is a cartoon depiction of a stage 1, an early stage lung cancer. All cancers are staged 1 through 4, 1 being the least invasive and 4 being usually the most and widely spread. So in this cartoon, you see a little small greenish yellow dot in the lung. This is a small spot of lung cancer that is stage 1. There's no evidence of disease anywhere else. This is the best chance for cancer. If you're going to have a cancer, you would want to have a stage 1 cancer. And here's why. This graph shows survival by stage. So on the bottom side, on the bottom of this graph, we have months in time from the diagnosis of cancer. So 0 time on the left would be when someone is diagnosed with a cancer. And then over to the right, 72 months would be 6 years from their diagnosis. And at the top of the chart on the left is survival. So we're looking at 100% survival. So the line that's closest to a horizontal line at the top means the most people survived. And each of these colored lines shows the stage of a lung cancer and what the estimated survival is. So somebody who has a stage 1A1, so the smallest substage, the earliest substage of a stage 1 cancer, 1A1, has a 97% chance of being alive at 2 years and a 92% chance of being alive at 5 years or 60 months. And you can see here, the stages are broken down into small substages, 1A, 1B, 2A, 2B. And the higher your stage, stage 4, the lower your chances of surviving to 2 years, 24 months, or to 5 years, 10 months. So this is why stage is so important, because the earlier stage cancers have a much better chance of survival, much better chance of treatment. So here's a couple of examples of what a stage 2B cancer would be: a little bit bigger cancer, some spread to some local lymph nodes. A stage 3B is, again, a larger cancer than that first one we saw, and lymph nodes are involved in the windpipe, just as some potential examples of how we determine the stage. So stage 4 lung cancer, or metastatic lung cancer, usually will have spread either outside of the lung where it originated, perhaps to the other lung, there are 2 lungs, or to lymph nodes outside the lungs, to the lining of the lungs, or to other organs like the liver, the brain, or the bones. This graph on the right shows survival for stage 4 lung cancer. Now, along the bottom here, we've got the year of diagnosis. So what they're showing here is, compared to 1970, people in the 2010s were doing a little bit better if they were diagnosed with metastatic lung cancer. The gray graph, which is the one on the top, shows 2-year survival. So how many people were alive 2 years after they were diagnosed? And that number you can see is steadily climbing. On the left-hand side, this shows the percent of people who did survive that long of a time, and it's still only between 10 and 15%. Those numbers are increasing now. This is from 10 years ago, and I am happy to report we've had even more promising treatments. But you can see here the number of people who have stage 4 lung cancer who are alive at 2 years and at 5 years is still quite small. And that explains why we saw those numbers that we saw on the table of how many more people are dead from lung cancer than many other cancers. So these are some different types of drug therapies that are used to treat people with lung cancer. People with stage 4 lung cancer are usually only offered medical treatments and not surgical treatments. So we have chemotherapy, which is what you probably traditionally think of as cancer treatment medication, makes people sick, might make them lose their hair. Targeted therapy and immunotherapy are new treatments which are available for lung cancer really in just the last 10 years or less. And these medications are better tolerated and more effective for lung cancer than some traditional chemotherapy regimens. In just the last 2 years, I mean, basically since the pandemic started, there are 20 new medications that have been approved for lung cancer. So this is really good news. We're going to continue to see that survival curve improve for lung cancer. I'm quite confident. All of those 20 different medications are used to treat different types of lung cancer. So lung cancer is actually many, many different types of diseases. This little pie chart shows a variety of different mutations, genetic mutations that develop in people with lung cancer. So earlier I mentioned EGFR. EGFR is actually one of the more common mutations of lung cancer. Those scientists recently discovered that pollution was contributing to some EGFR cases of lung cancer. So each of these different mutations now has different targeted medications, a specific medicine that is working to impact this genetic mutation that you see listed here. So this is really huge news. The treatment of lung cancer is changing very rapidly and is really, really, it's a really exciting time to be involved in lung cancer because we are doing more than we've ever been able to do for people with lung cancer. I will mention that lung cancer is typically divided into a few different subtypes. You might have seen on some of the other slides NSCLC, which stands for non-small cell lung cancer. So lung cancer is divided up typically into small cell, which is based on the fact that on the pathology slides, those cells are small, and non-small cell lung cancer. And non-small cell lung cancer, there are a variety of different types: adenocarcinoma, squamous cell carcinoma. So those refer to the type of cell that turned into a cancer cell. Most of the promising new treatments and really exciting updates lately have been happening for non-small cell lung cancer. Small cell lung cancer is an aggressive type of lung cancer, which is typically treated with radiation and traditional chemotherapy. And unfortunately, we haven't seen as many exciting new options for treating small cell lung cancer. So most of the slides that you've seen so far apply to non-small cell lung cancer. So now I want to focus on screening. I showed you why an early stage cancer is important. You're going to have the best chance of survival. You have no spread outside of the chest. And the way that we find those is with screening tests. So the purpose of any cancer screening test, whether you think of breast or colon cancer screening tests or cervical cancer screening tests, is that we are looking for cancer early. We want to find cancer when there's no signs or symptoms. A person feels healthy and well, but we know that they are at risk for cancer, and we go looking for it, and we find it before it has caused a problem, when there is a better chance of curing or treating the cancer. So the entire purpose of screening is to save lives through early detection. Here are some different non-invasive screening tests you might be familiar with. So mammogram is on the right, and then on the top, there's some x-rays of what it looks like on a mammogram image and how you find the cancer on a mammogram. On the left side is a fecal occult blood test. So this is non-invasive. It's not exactly the most exciting, but it's not invasive. And that's a test for colon cancer screening, where the colon, where the outputs of the colon, the stool, are tested for blood to evaluate for early signs of colon cancer. And then in the bottom in the center is a picture of a CT scanner. This is a person laying on a CT scanner going through to get a CT scan. And this test is now available to screen for lung cancer. So lung cancer screening is recommended for men and women who are between the ages of 50 and 80 years old, who have smoked cigarettes for quite a long time. We basically say people who have smoked the equivalent of a pack of cigarettes a day for 20 years should be screened for lung cancer. And if people have quit smoking, they should have quit within the last 15 years to be eligible for screening. Again, here's a picture of the CT scanner. It's a pretty simple and straightforward test. It's actually the easiest, least painful, least preparation of all cancer screening tests that are available. So in short, how can we work to reduce lung cancer deaths? Early detection through screening is really important, and that's one key component to the strategy that we're using right now. Early lung cancer, when detected, is more treatable, and there's a better chance of cure. Better treatments for lung cancer. We now have so many treatments that are much better tolerated and easier for people to endure and more effective to treat the cancer. And finally, we want to work to reduce cancer rates to begin with, reduce people even getting cancer. And the way people can do that is by avoiding exposure to smoke, by testing and avoiding radon exposure, and by us minimizing pollution, which is easy to write 2 words on a slide, but of course that's a pretty complicated problem in and of itself. What can you do if you smoke cigarettes? You should stop and avoid and minimize any smoke inhalation, including cigarettes. Test your home for radon if you haven't done that already. Get screened if you're eligible to be screened, if you meet those criteria. And if you have any respiratory symptoms, certainly you need to seek medical attention early. I think the point that I want to make here is that there is hope. Lung cancer is not a death sentence. We have some survivors here who are going to share that with us. But the most important thing is to tackle this problem early if you think you have a problem, so that there'll be a better chance for treatment. And this is a little bit about radon, but I want to stop here so we can save room for questions and other discussion.
Dr. Begnaud, thank you so much for providing such an in-depth presentation on cancer and lung cancer, the risk factors, staging types, treatments, screening, and as well how to reduce lung cancer. So next we will be hearing from 2 incredible lung cancer survivors, Steve Kuczenski and Chris Shillock. Both will be sharing their lung cancer journeys with you all today. First, we'll hear from Steve. Steve is a mechanical engineer who was diagnosed 6 months after retirement with stage 4 non-small cell lung cancer. He has a wife, 4 children, their spouses, and 5 grandchildren that have all supported him along his cancer journey. He has kept up life's adventures despite the cancer treatments. He has traveled to numerous countries across the continent, including Australia, Papua New Guinea, Kenya, Zimbabwe, Tanzania, Egypt, Morocco, Duluth, Peru, Ecuador, the Galapagos Islands, and Greece. His hobbies include golf, pond hockey, woodworking, and restoring a 1969 Opel GT. Steve is a volunteer driver with A Breath of Hope, and he provides cancer patients transportation to and from their many appointments and consultations. Driving patients allows Steve to pay back for his stable cancer status. I am honored to introduce to you all Steve Kuczenski. Steve, please tell us how your lung cancer journey began.
Hey, thank you, Amna. First thing, it's nice doing a bio and not a obituary, but like she said, I retired in 2016 in October, and I was in San Francisco with my visiting my grandchildren in San Francisco, and I got a gut pain at night, like 1 a.m. I got up, said, "Oh, this isn't good." So I kind of toughed it out for an hour, finally woke up my wife, who's a nurse practitioner, and she kind of put up with me for another hour and said, "Okay, I guess we should go to the hospital." We get to the hospital, and that's when all the bad things happen in hospitals after the bars close. So they didn't see me until 4, and the pain was going away. So they did a quick blood test to make sure it wasn't an appendicitis, and we came back to Minnesota. My wife and I were going to head to Africa to go on a mission trip for her church. And my wife said, "Well, since I'm a nurse practitioner, you better get your gut checked. So she told me to contact my primary and get a CT scan done of my gut. So talked to my doc. He said, sure, go ahead, do it. Had my scan done in the morning. He called me up late at around 5 o'clock that day and says, I normally don't do this over the phone, but we reviewed your CT scan and you have nothing in your stomach that's going to cause you any gut pain or issues. However, it appears you have lung cancer and it's spread to your lungs, your adrenal gland, and your lymph system. And it's like the hammer blow. You know, I'll always remember that date my whole life when that happened. Hung up the phone, talked to my wife, and, you know, she being a nurse practitioner went and said, adrenal gland? Why did it spread there? But I guess it's one of the places it goes. The reason the doc called, because he normally did it in his office, you know, if he's going to tell somebody he has cancer, is he scheduled me to go see an oncologist the next morning at 9 o'clock. So next day we're off to the oncologist and he reviews it and he goes and says, yeah, without treatment, maybe 4 to 6 months, you know, which is another, you know, hammer blow. So I said, okay, we got to do some treatment. So he scheduled up a needle biopsy of the adrenal gland, which the adrenal gland is nestled up, I guess, above your kidney. I'm an engineer, so it's above your kidney, below your lung, but it's underneath your rib cage. So it's a nice long needle that they go in and get that biopsy with. They pulled that off, got a tissue sample and confirmed that it was lung cancer, like they suspected, and sent that off for evaluation. Next, I had to break the news to my 4 kids. You know, 3 of them lived, 2 live in San Francisco and the other one lives in New York City. So we had to break the news to them over the phone, which is really hard. I mean, telling you, you know, that old dad here has got an issue that's pretty severe. From there, we moved on. I had to tell my coworkers because I was scheduled to be playing golf the next week, which I still play, so things are good that way. The biopsy came back and I had what was called 70% expression of the PD-L1 marker. And what I understand, doctor, please correct me if I'm wrong, but every cell in your body has 2 PD-1 markers on it, which tells your immune system that that cell's good and it belongs there. The PD-L1 markers tricks the immune system into thinking that it's good and it allows a cancer to spread. Fortunately for me, they had, within the year before I was diagnosed, they had approved Keytruda to be the treatment of choice if you have more than 25% expression of the PD-L1. And since I was 70%, they said, yeah, that sounds like a good idea. Let's go do it. I had a second opinion because, you know, you have to trust your providers. Went to the University of Minnesota, had them review it in Mayo, and they looked at the biomarkers and, you know, the PD-L1 expression and confirmed that Keytruda is the drug of choice. So I had my first infusion. Now you can think of it, I started in April of 2017 with my diagnosis. Now it's middle to end of May, I had my first infusion of Keytruda. And I would get it every 3 weeks after that. At first, it hit me with a really bad rash all over my body. I had dry mouth, fatigue, and I developed a debilitating cough where in the evening, the only thing I could do was lay on the couch and suck ice cubes, and I would cough from 6 o'clock until 10. Fortunately, I could sleep after that. So we went through 2 infusions of the Keytruda, 3 weeks apart, and met with my oncologist after a CT scan. And the good news was that the tumors weren't growing. Oh, I'm sorry. The good news was there were no new tumors, but the tumors were growing. So we were thinking, you know, he went and suggested, because he had gone to a medical conference in Chicago where they talk to each other about things they're trying with different patients. And he found some people suggested that patients on Keytruda do better if you radiate the tumors. And following his advice, we agreed that that should happen. And he decided the adrenal gland was the first thing to be radiated. Now, when they radiate the adrenal gland, they used stereotactic radiation, which means you're laying on a table. Well, to start with, you have the table, they put a beanbag chair on the table that you lay on that snaps into the table, and then they squeeze these beans all around you and then somehow draw a vacuum, and it forms like a shell that you lay in that fits your body perfectly. And they use that shell for all your treatments after that. Then they target you with 4 tattoos. They're about the size of a freckle. And so I was able to brag to my 4 kids that now Dad's got some tats to show them, you know. And they use the target tattoos to set up the path for the stereotactic machine that spins around, moves around you, and radiates your tumor from different angles so that you're not hitting important organs like your spine or your kidneys or other objects that don't do well with radiation. So the other thing that the advantage I had with the stereotactic radiation, it only lasts for 5 days. You go there for 20-minute sessions, 5 days, and it's done, because it's a very high dose that's very concentrated on the tumor. Had a couple more infusions of Keytruda, went into the doc, he checked me out and said, okay, looks like the adrenal gland tumor is growing. You know, it got bigger yet, but he says it might be because the Keytruda is doing its job now. So we had a scan 3 months later, and the adrenal gland then was getting smaller and looking positive. So then they decided to attack the 2 tumors in my left lung. And those 2 tumors in my left lung, they couldn't use stereotactic because they said that would kill me. So, you know, I agreed with them pretty quick. And they did general radiation on those. So that was 3 weeks, 5 days a week, where they just radiated the 2 tumors in the lung. Couple more infusions of Keytruda, another CT scan, and then they decided to do the lymph nodes. And the lymph nodes were between my aorta and my vena cava along my spine. So they were hard to get to. So they put me back on the stereotactic machine, and it was like a carnival ride because the table was moving and tipping and rotating as the head was going around, you know, and as long as that huge thing that weighs about 5,000 pounds doesn't hit me, I feel good about that. So that went well. I mean, the radiation helped. After the general radiation of the lungs, my cough went away, you know, and it was just in time for Christmas. So the kids were home and I'm not laying on the couch coughing my lungs out. And they really felt like, okay, things are starting to look good. We continued to go with Keytruda every 3 weeks. And after 25 infusions of Keytruda, I started developing a thing called ground glass opacity, which if you look at the CT scan of your lungs, it looks like you have a bunch of broken glass shards all over your lungs, little pebbles of glass all over your lungs. And it started in my left lung. So my oncologist said, okay, that could be a new form of cancer happening, or it could be the Keytruda attacking. So he reduced my frequency from every 3 weeks to every 4 weeks, thinking maybe I'd tolerate the Keytruda better. 3 months later, went in, and the ground glass opacity had spread to both lungs, and I was getting very short of breath. So he said, I think you're done with Keytruda, and put me on prednisone, and very high dose of prednisone. So I felt really good. I mean, like I was 16 years old. So my announcement is I've been treatment free since November of 2018. I'm a 5.5-year survivor of stage 4 non-small cell lung cancer. And I appreciate every minute of it. One of the things I did of September of 2021 is that I joined Breath of Hope to do driving of patients to and from their treatments. It was my way of paying back for my good fortune. In the car, they ask me questions like, well, why are you driving? And then I tell them kind of my story, offer them some encouragement, always qualify that every cancer is different and everybody's outcome is different, because it is. But so far, I've had 11 patients that I've taken to numerous treatments. So I don't know, last month I spent 25 hours driving people to and from their treatments. So that's what retired people do. You drive other people. So I think with that, I think I'm done, Amna.
Thank you so much, Steve, for sharing your incredible story with us. So next we will be hearing from Chris Shillock. Chris is 82 years old. He makes his home in the Elliott Park section of Minneapolis. He's written 3 small books of poetry and occasionally performs with his band Invisible Jazz. Chris has 3 sons, 3 grandchildren, and a great-grandson. Chris, please share with us how your lung cancer journey began.
Chris, you're muted.
Can you hear me?
Yes, we can.
Okay. Yes. I suppose it began when I was a teenager and started smoking, and ended up smoking 2 packs a day for about 50 years. And I always told myself, well, if it came to a point medically where I had to stop, I would. And about 15 years ago, I was 66 years old. I had developed COPD. I had trouble breathing. I went to the doctor and I stopped smoking. What I failed to think of was that once you have to stop smoking, that's because damage has already been done. My COPD got worse. I had increased shortness of breath. And about 10 years ago, I suggested to my primary care doctor that a chest x-ray might help. He said, oh, at your age, that does more harm than good. Well, my shortness of breath kept getting worse. So in 2014, he said, I've done what I can for you. I'm going to send you to a specialist, who fortunately was Dr. Begnaud. And the first thing she suggested was a chest x-ray. She said it might be good, even though Medicare might not cover it. So I had a chest x-ray right then. One of the things I love about the University Hospital everything is right there. You've got all the machinery. If your doctor can't help you, they'll send you to a world famous specialist down the hall or upstairs or something. But anyway, the good news was that Medicare covered it because I was diagnosed with, I believe it was stage 3 lung cancer. It had spread, and I started a course of radiation chemotherapy. It seems pretty straightforward. I heard really bad things about chemotherapy. I did not suffer the usual nausea that you hear about. I think they've improved the treatment over the years. And radiation, that went on for about 6 weeks. And the growth seemed to stop. Some of the extensions, I think, disappeared. Now about 3 years ago, again, they discovered a small growth on my lungs. I continue to go back about every 3 months or so. And I had the stereotactic treatment where they highly targeted radiation, which got rid of it right away. I didn't see that again. I did have several complications from it. One of them was I was getting blood clots, and I had to start taking injections, doing my own injections, actually, blood thinners. I had some radiation pneumonitis, which made it hard to breathe. I was on oxygen for a while. During this time, I had a number of other problems. The place I had lived downtown for about 30 years got closed. It was converted into expensive condominiums. So I ended up having to move about 3 times in the next 2 years. My job left town. I had that also to deal with, but my family, my friends, my community, the arts community reached out and took care of me. I found places to stay. People would rent me a room in their apartment. And eventually, actually my job moved back to town. Also, during that first year, a number of my friends came in to visit. I have friends in other countries, and I even managed to take a trip to Paris, see my friends there. They treated me like royalty. And so I guess I really appreciate what they have done. I've heard other people's stories where their cancers have not been caught in time.
Thank you so much, Chris, for taking the time to join us today and share your story with us. So we're going to transition to the discussion portion of our program today. So before we do that, I'm just going to get our fire going because it's not a fireside chat, especially during this weather without a fire. Okay. Perfect. Okay. So I'm going to go ahead and get started. I saw Dr. Begnaud answered all of the questions that came through during the presentation. So thank you so much for doing that. So if you had any similar questions to what was submitted, go ahead and check out the answers that have already been submitted. So I will go ahead and I'll start off with this question, and I'll open this question to I think to all of you. So Dr. Begnaud, Steve, and Chris. So how can I talk to a loved one who smokes about lung cancer and their risks? Is it important to have that conversation? And how do you do that effectively?
Would anyone else like to start?
I think, Chris, if you can start.
Okay. Yes. There's really not much you can say. I started smoking in 1956. I think that was about the year they discovered that it causes cancer. I kept on smoking until I had to stop. I have 3 sons, 2 of them were heavy smokers. And it's hard to talk to people about an addiction, any addiction, and smoking is the hardest addiction to quit, even worse than the drugs like heroin, things like that. It satisfies everything you want. It's like having a friend for 50 years to help you out, and then he kills you. If there's still a friend, it's I say I don't think there's much you can say except remind people.
Thank you, Chris. Dr. Begnaud, do you have anything to add?
Yeah, I think I would say, what Chris has shared, a lot of my patients have shared. So the first thing I would say is, yes, it's important to consider having that conversation, but I think you need to lead with your heart, and to be empathetic, to recognize, as he said, it is addiction. It's something many people don't want to do anymore, but they still continue to do. And I've had many people tell me cigarettes are my best friends. They've always been there for me in the ups and the downs. So I think it's really important to recognize that people who are addicted to smoking cigarettes already experience a lot of self-inflicted blame. They experience a lot of external shame and stigma. And the last thing they need is to get that from someone who they love. So yes, it's absolutely important to minimize or completely quit smoking. Even if you have lung cancer, it's never too late to stop. Your body will respond to treatment better. There's less of a chance of the lung cancer coming back if you have it successfully treated, if you have quit smoking. But those people need a lot of support, and they need a lot of empathy to help them get through that with you, and not just you there nagging them.
Great points. Thank you so much, Dr. Begnaud. There was a question that was just submitted, and I actually, Dr. Begnaud, if you can take this on live, is there a way to test your home for radon?
Yes, so the test kits are, I'm crafting the little response now so everybody can have it. The test kits are inexpensive. You can buy them in most home improvement stores. The Minnesota Department of Health also has some available. So testing for radon is pretty easy. You buy a test kit, you leave it in your home, and it will test over a period of time. It'll measure, and then you send it off to a lab and they run the results. The hard part about radon is that if you have high levels in your home, it can be expensive to mitigate them. So I have a radon mitigation system in my home. The time that most people learn about this is when they're in the process of a home sale. That's usually when it happens. It's not required by law to happen, but if a seller of a home knows that they have high levels of radon, it is required by law for them to disclose what the levels are. And then the mitigation system, they cost, I think, a few $1,000s. It's basically a vent and a fan that sort of filters it and pushes it out into the air. So testing is relatively easy. Mitigation can sometimes be a bit more complicated and expensive.
Thank you so much for providing that link too.
Dr. Begnaud, if I could ask, supposing you live in an apartment.
Yeah, that's something that sometimes keeps me awake at night, because we don't have any regulations in Minnesota about people who live in multiple dwelling homes, or if you're in a rental property. We don't have any regulations that would require the landlords or the owners of that property to do something about it. So I'm not quite sure what to advise people. I think, one approach might be to say, well, if I can't do much about it, maybe I don't really want to know. The other approach might be to test and then see if you can get something done about it. But I don't think there's any regulations that require landlords to do it. So they would really be doing it out of their own, goodwill.
Thank you so much. That's a good point, Chris. Thank you for bringing that up.
Yeah, the thing about radon too, I test my basement, and I think the cutoff level is 4 for radon. And like I get 4.5 during the winter, and obviously during the summer, the house is open and it's very open. The other side of my house is where I brew my beer, and that's like 1, so it varies in the basement. And when you go upstairs, I don't think it really travels or accumulates upstairs, is my opinion. But What do you think of that, doctor?
So I will tell you that it does circulate throughout the home. A lot of people are, of the impression that the basement is the main area where it is. But of course, there are, homes have ventilation systems which can circulate it throughout the home. So there's really no specific type of home or building, I should say. There's no specific type of building. There's no specific age to the building or really anything that is kind of a reliable indicator of whether or not you might or might not have high levels in your home. You're totally correct that in the wintertime in Minnesota, most of us have gotten our homes closed up, and we're not trying to get external air in here. And so the levels are almost certainly higher in the winter rather than in the summer when you've got circulation of outdoor air coming in. But the levels can vary throughout the home. Of course, the basement is closest to the ground where it's coming from, but it can circulate throughout the home. So when you get the test kits, they give you some specific instructions about where in your home you should place it. I believe for my home when we did it, I think they actually had 2 kits and then they sort of averaged the results. So there is some strategy to that because it's not uniform throughout the entire building.
Okay, so we'll go ahead and move on to another question. So Steve, I'll actually ask you this question. Is it possible to live a quality of life with lung cancer for more than a few years? I mean, you are living proof of that. So please tell us how you've been able to do that.
Since I'm at 5.5 years, I'd say yes, it's possible to live quality life. You'd have to keep active. One of the things is plan vacations ahead of time, 6 months to a year out, and inform your oncologist, when you'd like to take these vacations, because sometimes they tailor the treatments around those vacations because they realize that people like to still go places and see things. Yeah, I guess it's very possible. The idea is I'm not going to let it control my life. I'm going to cope with it as I can and, see what happens in the future.
Love that. Thank you. Chris, do you have anything to add? Is it possible to live a quality of life with lung cancer?
Well, my disabling effects were more from the shortness of breath, which I've been continue to see Dr. Begnaud about. Yes, I managed pretty well. I've never been particularly athletic or done anything like that. I go out a lot in the evening. I've continued to do that. So yes, my answer would be yes.
Amazing. Thank you. And Dr. Begnaud, do you have anything to add? Is it possible to live a quality of life?
Yes, absolutely. I really appreciate you having Steve and Chris here, both of whom are, Steve, I think you said 5 years. Chris, it's been 8 years since you've been diagnosed with lung cancer. So, I mean, the message I really want people to leave here with is that lung cancer is a serious condition, but it is not a death sentence and is not game over. And you certainly deserve to be taken care of by people who are your partners in that and want to help you live your life, just like you both said. You have to fit in your treatment, but you also need to fit life in, and I'm absolutely willing to do that, and I think most doctors are. So the answer is yes. If not now, when?
Very true. So I'll ask you all just one final question as we wrap up things today. But do you have any message, advice, or words of wisdom for our audience to help raise awareness about lung cancer? So what are your key takeaways that you would like the audience to know today? And
I'll go last. You guys go first.
Okay.
Steve?
Okay. One thing I often stress, because my family, my extended family, I have 4 sisters and 4 sister-in-laws and all their kids. And they knew right away about my cancer diagnosis. And I send out a challenge update telling them what the status is, and what treatments I'm doing. A lot of their responses were, "Why did you get cancer? You never smoked," and I replied back to them. I said, secondhand smoke was really bad 30 years, 40 years ago in the offices I worked in. The air was blue in the conference rooms, and at 4 o'clock on Friday, that's when 80% of the engineers all decided it's time to light up a cigar in this little office, and it's just ridiculous. But getting with the family and explaining to them that smoking is a choice, but it is an addiction, and that you can still get lung cancer, and explain to them about the radon and other mitigating factors. I worked in industry for 40 years, and a lot of times I probably should have been wearing a respirator when I didn't, just because they were hot, sweaty, and inconvenient. Looking back, it's my fault. I didn't do it. And I suggest to people to wear respirators when they're in conditions like that. I hope that answers.
Yeah. Thank you so much, Steve. Chris?
Yes, I think there are things you can do, perhaps by example, to keep people from smoking. It's not cool anymore. You used to be when you're a teenager, but it isn't really. So that's one thing. Other than that, I think you have to discover things by yourself. When I got cancer, actually, it was kind of like a good training for the COVID to come along. You find that you can do things that you never had even imagined, and you can get through it.
Thank you, Chris. Dr. Begnaud?
Yeah, I'll stick with Steve's theme, I think, which is that I think the most important takeaway is that you do not have to smoke to get lung cancer. People who experience lung cancer and their caregivers really experience a lot of stigma and blame from others, or just like you said, how did you get lung cancer? You never smoked cigarettes. I mean, our lungs are exposed to everything in the air around us, pollution and smog and radon and secondhand smoke. And increasingly, we are seeing people who have never smoked to develop lung cancer as smoking rates are going down over time. So, the number one thing I want you to remember is that lung cancer is not a death sentence. We have many promising treatments now, which continue to allow people to live happy and healthy and vibrant lives after a diagnosis of lung cancer. And really, just like you wouldn't ask any other such personal questions of somebody with whatever other kind of cancer they have, you really shouldn't be inquiring that about people with lung cancer as well.
All right, amazing. Love that. All of your answers. So unfortunately, we are out of time and we are over time, so we'll have to leave it here. But thank you so much, Dr. Begnaud, Chris, and Steve, for being here with us today and helping us raise awareness about lung cancer this month. So you will all receive an email shortly following today's program with a link to complete a quick survey. We appreciate if you could spend a few minutes to provide us with your thoughts and feedback about the session today. We'll use this information to plan future programs and fireside chats. After completing the survey, you can enter to win a swag bag with goodies from the Masonic Cancer Center. The Amazon $5 e-gift cards will be mailed out to all attendees in the next few days. And also stay tuned. Our last fireside chat of the year will be on December 8th from 1 to 2, where we will be discussing clinical trials. So please be sure to follow the Masonic Cancer Center on all of our social media platforms to stay up to date on our future announcements and events from the Office of Community Outreach and Engagement. Thank you again, everyone, for joining us today. We hope to see you soon, and I hope you all have a wonderful rest of your day. Take care, everyone.
Okay.
Bye now.
Thanks.
Thank you. Thank you,
Thank
Dr.
you.
Begnaud.
Such a pleasure, Chris and Steve. Thank you so
Yeah,
much.
good to see both of you. Thanks for joining today and sharing your stories. It's really important.
Thanks, Dr. Begnaud. Appreciate you.
Yeah, good to
Bye-bye.
see you. Bye-bye.